just jump right into the pathophysiology here of vertical heterophoria and superior oblique palsy. Can't hear me. All right, better this way? Yeah. All right, good. All right, let's just jump into the pathophysiology. And we're going to start with vertical heterophoria first. And this is not dry. This is actually really very cool. And if you can understand how this works, it'll make sense to you. And if it can make sense to you, it should really be able to make sense to insurers and other people as well, because this actually is something that's logical. This isn't just voodoo. So our research is indicating that a brain injury, that in the brain injury mechanism, VH or SOP is occurring because there seems to be a faulty signal being generated by the brain, such that the line of sight from one eye is aiming slightly higher than the other eye and is crossed, just like you're seeing here in the picture. Now, this happens to be a comfortable position for the eyes. This is where the brain thinks the eyes should be. However, if they're left like that, you're going to end up with double vision. And it turns out that there is a very high functional demand that the brain not see double. It's just dysfunctional. So all kinds of things are going to happen now to prevent the double imagery. The first thing that's going to happen is that the brain's going to use the eye muscles and rotate these eyes so that they're looking straight. But there's a cost to this. You're straining those eye muscles when you do that. Matter of fact, there is a conflict going on here because the faulty message is trying to pull the eyes in the wrong direction. The corrective mechanism's trying to bring the eyes back into the right direction. And what you're really doing is you're getting these eye muscles, these opposing elevator and depressor eye muscles are in a tug of war. They're totally overutilized. And they get strained and fatigued. And eye muscles are made out of the same stuff as the muscles in your arms and your legs, skeletal muscles. So you know what happens when your arm and leg muscles get overused. So these fatigued muscles, the strained muscles are going to be achy and sore, and people get headaches. So that's where the headache origin comes from. The fatigued muscles quiver, and they actually have the eyes, since they're attached to the eyes. When the muscles quiver, the eyes quiver. Half of our patients will tell us that they have a visual hallucination of movement. The letters look like they're wiggling on the page, or that they're shimmering, or that the words seem like they're bumping into each other. And even some dyslexia, I'm thinking might be, 1, 2, 4, 3, 5. How did things get turned around? Is it their brain or are their eyes actually overlapping the images? So the sensation of movement on the visual axis is now not matching with the inner ear vestibular system, which says there's no movement going on. What are you talking about? So the mismatch of your sensory inputs is what's making people feel dizziness. And when we say dizziness, we're talking the entire vestibular panoply. Lightheadedness, dizziness, trouble with balance and coordination, nausea, from which motion sickness comes from, all of that. Turns out that dizziness makes people anxious, just like anxiety makes people dizzy. So it's not uncommon with your anxiety patients that they have dizziness as a symptom. It's not so uncommon with your dizziness patients that they have anxiety as a symptom. So if you're going to break this cycle, you really got to know which direction you're going from. Are you going to be treating them psychiatrically, or are you going to be treating them for their dizziness, which in this case is actually tracking all the way back to their eye alignment? So there's a second compensatory mechanism. Let's see what I forgot to do. Oh, there. Second compensatory mechanism is a head tilt. So if you have one eye that's literally aimed slightly higher than the other, wouldn't it make sense just to tilt your head to try realign things? Well, it turns out that works. And that's exactly what they're doing. And that's why they tilt their head, because there is no other reason. They're uncomfortable. It's causing them discomfort in their neck. So there is an overriding mechanism to try and prevent the double imagery. So back to this wonderful slide. What we end up doing then is we use prismatic lenses to realign their images. So we're going to insert the prism. The line of sight moves from where it was to where it needs to be. Now that it's done that, the eyes can rotate back to where they were, for starters, which, mind you, is the faulty position, but it's the comfortable position. So now the eyes are in their comfortable position, and the prism is aiming the light so that they're aimed towards the target, and that's perfect. They're seeing where they need to see, and their eyes are where they need to be. So once they stop trying to compensate for this, they get 80% better. They stop straining their eye muscles, they stop tilting their head, and things are improved. Superior oblique palsy. I did all the animation myself, can you tell? Superior oblique palsy is a condition where one eye is higher than the other eye. There's one problem. It's a monocular problem, not a binocular problem. So in this model, it's going to be the left eye that's blue that is going to have the problem. So the first part of the problem is that with superior oblique palsy, the eye elevates. So now the eye is elevated above the black line. The other thing that happens is that you end up with an external rotation of the eye. like that. So now you've set up a real problem. They have double vision in 2 planes, vertically and what we call torsionally or rotationally. So for the body to try and balance back up with that, what it's going to do is tilt the head. At least now you've got this eye that's stuck out to the side in a vertical plane like it should be. And it turns out that the other eye, the uninvolved eye, is able to catch up because the muscles all work there just fine. So it's going to actually twist to match it. So now you've at least got the eyes oriented properly vertically, but you don't have them on the same plane. And that is a problem that remains with our patients that have superior oblique palsy. But that's the pathophysiology, and it is significantly different than VH. So, factors that trigger or worsen VH, I believe, is you, isn't it? All right, back to Dr. Debbie.
7 minutes, we're not out of time. Yeah. So what are the factors that trigger or worsen VH and SOP? Vestibular stimulation. Anytime the patient would go like this, it would make them dizzy. Anytime they would go like this, it would make them dizzy or disoriented. When you put Prism on them in front of their eyes, they can do these head movements comfortably. Looking from near to far would trigger for them dizziness. Visual stimuli like reading, action movies, 3D movies, certain wallpaper or carpet patterns, all types of optokinetic stimuli. Complex visual environments like malls, we talked about, grocery stores, crowded rooms. A significant prescription difference between the 2 eyes. Traumatic brain injury, intense near-point work, computers and reading, if there's a mistake in their eyeglass lenses in the prescription, or surgery, cataract, LASIK, eyelid tightening. If any one of us were to take our baby finger and press ever so gently on one of our eyes, you can actually see misalignment. It only takes a nickel's worth of pressure to see misalignment. So if you have someone getting eyelid surgery and they look cosmetically amazing but all of a sudden get dizzy, it may be connected to their eyes now being misaligned from that slight pressure on the eyeball. So what is the recurrent theme with these patients? They've been symptomatic and having their symptoms for a very long time, seen by many different care providers. Many tests performed, CT, MRI, audiogram, ENG, EEG, Holter monitor, many medications tried, many procedures performed. These symptoms aren't being recognized as syndromic for VH and SOP, and sorry about that.
I did it.
Okay, so I'm going to let you control it. So what are the 3, so let's talk about this questionnaire.
I'm messed up. Hold on. All right, there we go.
Okay. Questionnaire? No? Okay. So what are the 3 roadblocks to diagnosing this condition? First of all, the symptoms aren't being recognized as even due to a binocular vision problem. My patients will often go to the neurologist, the ENT, way before they would ever imagine that it was related to their eyes. So what is this questionnaire that we keep talking about? All of you have it in your handout, and there is an adult validated version and now a pediatric version, which we're looking to validate. It is the most powerful and consistent tool to identify VH and SOP suspects. As Dr. Doble mentioned, she does it with new patients, and then she'll redo it in 3 months. Dr. Rosner does not send one patient without using this questionnaire. Very clear cut on the importance and the use of it. And it's built on the Likert scale. So 0 is never, 1 is occasionally, 2 is frequently, and 3 is always. It has a score, anything greater than 15 is considered abnormal. And as you will notice, all of you have a very specialized one in your hands. We've taken the time to identify the red flag questions. And those red flag questions are the ones number 2, number 13, number 15, number 16, number 18, 19, and 24. What are they? The headache gets worse with eye movement. There's a clear-cut head tilt. There's double vision at near and far. If they close or cover an eye, they feel better. They skip lines with reading. What's the second roadblock? Vertical alignment measurements used to diagnose these 2 conditions are just not sensitive enough. So we use something called the Prism challenge technique, which you've heard me describe, where I'm applying the script, I'm applying the Prism into the test frame to prove, have we really reduced these symptoms? Have we gotten rid of your headaches, your dizziness, whatever those symptoms were that you came in with? And then the third roadblock, which is a powerful one, is that the correct equipment just did not exist. So much of it had to be invented. I want to credit my father, Dr. Paul Feinberg, not only with telling me how long I could take, which was as long as I needed, but he was the actual inventor of many of the tools that I use to this day. The results of treatment, a third to a half reduction of symptoms within 20 to 30 minutes of the Prism application, and 80% improvement by the end of treatment. Where do patients go for care? I would say everywhere, but they go to so many different medical specialties, unfortunately not getting the help they need. And now if we begin to move it forward to the specialized trained optometrists, we can begin to help this population. They are now coming from too far away, and so we're looking to help train colleagues from out of state so we can move this work forward. We're grateful for them to come to get care, but we know it needs to move into a different realm. Over 400 patients have come from other states. And I'm going to go back to Dr. Rosner. I think he's just got about a minute or so.
No.
Or 3 minutes or so.
Actually, it's longer, so we're probably going to run a little late. We understand if you have to get up and go to the next place, which actually is lunch, but if you can stay, that would be wonderful. And we were going to finish the lecture. So, research and academic activities. Okay, we can tell you all day long just how great this is and how wonderful it is and have patient testimonials, and it doesn't count for anything in the academic world. You got to prove your stuff. So we did write one paper in 2010, and we've got about another 6 that are halfway done, which is what I've been taking the time off to do. So it turns out that we got a data set with 126 patients that had complete data. 38 of them were traumatic brain injury patients. So we're going to work on that subset here today. All right. Average age was 38, but the range was from 12 to 67. 2/3 were female. And average duration of symptoms was 10 years, which is not uncommon at this point in time, 3 months to 30 years. They almost all had neuroimaging. It turned out that about 2/3 had an MRI or a CT. Half of them had both. You can see the costs up on the slide. It's expensive to be doing this, so we're investing a lot of money and not actually getting a lot of answers for the money that we throw at it. They've seen a lot of specialists prior to making it to us. On average, there's 3.7 consults per patient, and these are the ones we asked about. So neurologists, physical medicine and rehab, ophthalmology or optometry, family practice or internal medicine, psychiatry, ENT. And then this is a slide where kind of the meat is. So this is going to talk about the percent reduction of these symptoms, headaches, dizziness, and anxiety with prismatic lenses. So the first part of the slide discusses overall data. And what we did for this is we captured our data before we treated the patient, and then we ran the metrics again after the patient was treated and they were feeling better. And this is representing the percentage difference or decrease in these different categories. So the first line with the overall data is the BVDQ. That's the questionnaire you've got. That score reduced by 50% in our patient population. The visual analog scale, or VAS, is a line, 0 to 10, and you mark on it how much better you think you feel. They felt 80% better on average at the end of their treatment. Now, with regards to the next 3 data sets, the headache, dizziness, and anxiety data, we ran 3 different types of data collection. The first was a specific metric that was validated in that particular symptom. So for headaches, it was the HDI, dizziness, the DHI, and for anxiety, it was the ZUNG. Then we went ahead and we ran the 0 to 10 questions. You know, how do you feel right now on a 0 to 10 scale with regards to your symptoms? So it's subjective. And then the last thing we did was we analyzed the questions that were within the questionnaire itself, the subset. So it turns out there's 2 headache questions, 6 dizzy questions, and 3 anxiety questions. And we took a look at their scores before treatment and then after treatment. So what are we finding out when we break it out this way? Well, we're finding out that the scores for the individual validated questionnaires drop anywhere from 20 to 40%. The 0 to 10 questions drop anywhere from 33 to 60%. And then the subset analysis questions reduced by about 40 to 50%. These are all hugely statistically significant if you take them to a statistician. Even my worst number, which is the anxiety one, 19%, is wildly statistically significant. The other are just amazing. We then took our questionnaire and we took a look at it. There's 25 questions in it. And we said, okay, how are the binocular vision questions doing? And it turns out that they don't rank very high. People don't really have a lot of binocular vision symptoms that we traditionally associate with binocular vision. Only the skipping lines and the head tilt were in the top half. The rest of them, they were 21 through 25. So honestly, if they say they've got one of these, they need a binocular vision evaluation. But if that's what you're looking for, you're going to miss this condition totally. All right, we went ahead and then took a look at what the top 10 questions were. What were they answering yes to? Well, they skip lines while reading is the only binocular vision question. That's number 10. But then you've got the pain questions that are 1 and 2, and then you've got the dizzy, lightheaded questions that are 4, 7, and 8, and 9, and then the last are vision questions, glare and other things. So you've really got to ask the right questions if you're going to come up with the right answers. So the conclusion we're making from this is that binocular vision dysfunction appears to be causing post-concussive symptoms in about 30% of all these people with persistent symptoms. That the TBI or ABI is causing or worsening the BVD that was already there. That if you can treat the BVD with prismatic lenses, you're going to get an 80% reduction of your symptoms. And that we can identify suspects fairly easily with the questionnaire. And that we diagnose them firmly with the Prism challenge test, where we put the Prism on them in the office and they actually go, wow. So we have studies going on in the office right now. We've got a randomized control trial, and the questionnaire has been validated, but it's published. And then we have an ED study going on. Turns out that 3/4 of the people that come to my emergency department complaining of I have a headache disorder and today's just terrible and I need medication help, 3/4 of them actually seem to have this as the cause. So, which patients should you screen for VH and SOP using this questionnaire? Anybody who's got these symptoms, the standard one, dizziness, headaches, neck ache, reading difficulty, anxiety, and if you're a TBI, if your symptoms have been present for longer than 3 months. By 3 months, your brain has pretty much settled down and most of the acute healing has happened, and if you're still symptomatic, you really have to think about it. Certainly you should think about using the questionnaire on those that have physical findings, elderly that are having difficulty with balance and frequent falls, which is an area we haven't gotten into yet, but I think it's going to really yield high. We have, anecdotally, I can tell you, we have older people that fall, that come in, that get their vision corrected, that don't fall nearly as much and their balance improves markedly, but that's anecdotal, that needs to be researched. And then chiropractic neck pain, the people that keep going and they keep needing to get readjusted all the time. Children that we're labeling reading and learning disabled. They might not be. It might be visually mediated, and we're just not picking up on their visual problem. Children that are being labeled as hyperactive. Well, if you're in 2nd grade and you're told to sit and read something and you can't read it, what are you going to do? You're going to move. Oh, I'm sorry, you're hyperactive. All right, children with motion sickness or car sickness. If you have a child that you know of that's sick in the back seat of the car, they have this. I don't know anything else that causes that. Watching 3D movies, that really triggers this. Agoraphobia. Once again, we think that this is probably the root cause or one of the major root causes of agoraphobia, and panic attacks. This is a common cause of panic attacks too. Refer anybody who scores high on the questionnaire or who has a positive answer to any of those red flag questions. What I mean by that is there's a never column. That's not a positive answer. The other 3 are positive answers. You shouldn't really ever be seeing double. I mean, you shouldn't. Not even a little bit. All right, this is the research team. This is our lovely office team, my wife with my father-in-law, Dr. Maury Dubin, who just celebrated his 92nd birthday, and he is the oldest living practitioner of neurovisual optometry. And then Mary Jo Ferentz just joined our staff in July. She's a wonderful addition. Okay, and then I just want to leave you with, it's our hope that the information we've given you today will open up the door to a whole new set of possibilities for your patients. I suspect that when you go back to your practice, you will recognize this condition in some of your patients, some of whom have not gotten better despite everything you've tried with them. And then this quote I love. I found this when I was doing my research. Dr. Mitchell from 1876. Who indeed could have supposed that a mere ocular defect could have given rise to so serious a train of evils? And who that had not seen it could believe that the correction by glasses of the eye trouble could have given a relief so speedy and so perfect that the patient described it as a miracle. So once again, these are visual orthotic devices, just to let you know, they're not glasses. And we wonder if Picasso had some of this too. And that's it. So thank you for sticking around. I know we ran over.